So as you heard, I also still do, next to my clinical work, a lot of experimental research. I have my own research group. That's why I also have some conflicts of interest to share. I have a lot of research support from several companies. I have separated my talk into 3 different parts. I will talk a little bit about the VKA reversal to remind you about some principles, and then I will talk about the DOACs, and then talk a bit more in general about the use in acquired coagulopathy. Just to set the stage for this talk and to remind you again, 35 million patients are about in the US under oral anticoagulation. About 6 million patients are on chronic anticoagulants currently, and we have about a rate of 10% that requires annually an invasive procedure. For those patients, either on DOACs or on VKA, we have to have a clear strategy how to reverse the anticoagulant therapy. And if you see here, over the years, we have a change in demographic, which means we see more patients when they turn older with AFib. And all these patients, of course, require an anticoagulation therapy. Warfarin, still the blockbuster, still #1 worldwide, was initially introduced in 1954. It has an anticoagulant effect by blocking the vitamin K cycling proteins, which leads to inhibition of the factors 2, 7, 9, and 10. As you know, most patients just require an INR between 2 and 3. Some do require a range to 3.5, but we can see if we cross actually this border, we have a severe risk of major bleeding, including ICH. In the discourse, how should we treat those patients? Should we use fresh frozen plasma, or should we use a 4-factor PCC? Fresh frozen plasma, to remind you again, mainly contains water, 92%, some plasma proteins. But if you look actually at the concentration of fibrinogen or the coagulation factors, it's really small amounts, which means that we have to give a lot of volume to replace the coagulation factors in bleeding patients to sufficient levels. In the context of this talk, it's also important to remember and to see that we have different prothrombin complex concentrates. So we have the 3 factors, which contain the coagulation factors 2, 9, and 10, small amounts of factor 7, activated PCC, also called fiber, which contains activated coagulation factors. But in the context of this talk, and this is actually what we pretty much use across Europe, is a 4-factor PCC, which contains the coagulation factors 2, 7, 9, and 10. We have different 4-factor PCCs also in Europe, and they are all only standardized on factor 9. Why is that? Because the 4-factor PCCs were initially developed for the treatment of hemophilia B. Of course, now we have different products for hemophilia B and treatment, but all other coagulation factors, 2, 7, 10, and also the anticoagulant proteins, CS and antithrombin, are all in these different PCCs at different concentrations. And that's important to remember that these are not standardized. Also, most of them contain heparin. So if you have a patient with an HIT, heparin-induced thrombocytopenia, you should not use this 4-factor PCC. One major advantage in using a 4-factor PCC is a high concentration while giving low volume. So 1 vial of PCC, 60 mils. This is like 3 vials of a 4-factor PCC of 500 units each. It's about equal to 1,500 mils to 2,000 mils of a fresh frozen plasma. We had early here some laboratory data, which are nicely shown the facts of the 4-factor PCC. And this is a thrombin generation curve. And you can nicely see, I think most of you are not much familiar with that. You stimulate with phospholipids and tissue factor, and you can see the activation of thrombin generation to a peak, and then again the inhibition. And this is blood from healthy volunteers, which were spiked actually here with warfarin, and you can see this flat curve and also the prolongation here of the initiation of the coagulation process. After the substitution ex vivo of recombinant factor 7A, you see a shift a little bit here in the lag time, but there's no difference in peak height, which means that recombinant factor 7A should not be used to restore hemostasis and warfarin anticoagulated blood. However, if you use a 4-factor PCC, we can see nicely a dose-dependent increase in the thrombin generation curve. So what's the clinical evidence? The first studies, which I'm not going to show you, were actually performed in Berlin by Hanno Ries, but the milestone study here was from Cerodi, which was published in 2013. This was actually the licensing trial to bring the 4-factor PCC also to the US. Patients which were bleeding were randomized to receive either a 4-factor PCC or fresh frozen plasma. And the dose here, as you can see, of the 4-factor PCC between 25 and 50 was based on the baseline RNI. Similarly, the fresh frozen plasma dose again was also based on the INR. The primary endpoint was the reversal time to INR correction. And as you can see from this graph, after giving the 4-factor PCC, there was an immediate reversal. Very effective. Whereas when the fresh frozen plasma was given, there was a high delay. And this is also shown here in this chart. Start of infusion and INR reduction within 20 minutes, whereas the time actually of giving the 4-factor of giving the fresh frozen plasma was much longer, which of course also delayed the start of surgery in the group of receiving fresh frozen plasma. So clearly in this study, 4-factor PCC was superior to plasma for INR reversal and achieving effective hemostasis. This was the milestone study by Cerodi and Goldstein. What's about ICH? We know this is the most problematic what we have in patients when they bleed because of the worse outcome. And this is a study here from Germany, from Thorsten Steiner. He treated patients, again, according to INR with an ICH, and they received either fresh frozen plasma, 20 ml per kg, or 30 units per kg of a 4-factor PCC. The nice part of the study, after screening, already 3 hours after inclusion and after therapy, they did already the first CT scan. And it was shown that those patients that received a 4-factor PCC showed less volume growth. And these data also indicate that it's very important to give the 4-factor PCC early on, especially in those patients which are most critical, some patients which have an ICH. And together with Edelgard Lindhoff-Last, we also did an observational study over the last year, both for DOACs and VKA bleeding. And this is the time data for the duration of bleeding with PCC under VKA. And you can see here, without PCC and with PCC, there was a significant shortenance of the duration of bleeding in those patients with ICH bleeding that received the 4-factor PCC. So clearly, there are pretty good data, robust data now where we use the 4-factor PCC for bleeding that is associated with VKA. All-cause mortality here in this meta-analysis, 3 randomized controlled trials, also showed a favor of using 4-factor PCC as fresh frozen plasma. One thing that is always important to remember, we know the 4-factor PCC are highly thrombin-generating drugs. They are highly effective in restoring hemostasis in the setting. So we actually feel there's a risk of inducing thromboembolic complications, but we see from these studies and this meta-analysis that there was no safety signal. So which means that the 4-factor PCC was equally safe as fresh frozen plasma, so no difference in adverse events in the setting of the VKA reversal. So the advantages, of the use of a 4-factor PCC as summarized here. There's a reduced risk of transfusion of TRALI. There's a reduced transfusion-associated cardiac overload due to the small volume. You have seen the faster INR reversal, and I also will show you some data which have shown cost effectiveness. I'm aware that many countries still use a three-factor PCC. Again, in Europe, pretty much, we only use a 4-factor PCC. And there are also some comparative data. So this is an older study, a retrospective analysis following a trauma and acute bleeding under VKA. 87 patients were included. And you can see that the 3-factor PCC, and this was pretty much the US approach, was also substituted plus the recombinant factor 7A to substitute for the lack of the factor 7 in the 3-factor PCC. And this cohort was compared to the 4-factor PCC. The INR post-reversal was a bit better in the 3-factor PCC. However, the units which were used here to achieve this result were much higher. And please also remember that here in the study, 3-factor PCC was substituted plus factor 7A. Another study here, retrospective study again with acute bleeding, 3-factor PCC versus 4-factor PCC. The initial dose was comparable. However, the total dose needed for reversal was lower in the 4-factor PCC. And successful reversal in the study was also defined as an INR less than 1.5. And this is shown here in this graph. You can see that those patients here with black lines, this is the group of the 4-factor PCC, had a higher success rate, a significant higher success rate in achieving this lower INR of 1.5 as compared to the 3-factor PCC. And the overall costs were also being shown to be cost effective in favor of a 4-factor PCC. So in the context of VKA reversal, for me, where we also have the depletion of factor 7, there is no indication to use a 3-factor PCC because you are lacking this factor 7 in the 3-factor PCC. I have a colleague who just did a meta-analysis again. My colleague screened about 410 studies. 11 studies only were included, so it's actually very poor evidence if you look over the all evidence. However, in this meta-analysis, which has not been published yet, she could show that the 4-factor PCC was more effective in reducing the INR. Some practical guidelines, of course, if we have an elevated INR with no bleeding signs, we just wait. We do not give a 4-factor PCC, but we should just hold the warfarin dose, increase the frequency of monitor or measuring, and at very high levels here at an INR above 5, 6, 7, you can consider also the application of vitamin K, but please do not give a non-bleeding patients a 4-factor PCC for reversal. Only in those patients which are bleeding, and this is here also stated in the European trauma guidelines, as well in the guidelines from the European Society of Anesthesiology, to use a 4-factor PCC plus the vitamin K as first-line treatment in bleeding patients under VKA. And also to show you our label here in Europe, it's a very broad label actually. It says acquired deficiency of the prothrombin complex coagulation factors, so 2, 7, 9, and 10. If we have patients that are bleeding and have some acquired deficiency signs of that, lab signs for instance, we are in the label of using a 4-factor PCC. Dosing recommendations, I would like to refer actually to the labels of the different 4-factor PCCs because they show you stratified according to the INR, the different doses, for instance, here for octaplex, which should be applied. One important thing here, and this was actually quite surprising for myself, that it was investigated the time and actually was used to give the 4-factor PCC to patients. And these are data from the UK. And the total time from the patient coming to the hospital to giving 4-factor PCC was an average 127 minutes. And this is, of course, unacceptable, especially for those patients with ICH. And this long time was due to hematology consultation, collection of PCC from the transfusion laboratory, and obtaining the laboratory INR results. They changed their algorithms. So what they did was the POC testing near the emergency department. They also put the PCC into the emergency department, and they had an autonomously driven protocol to give the 4-factor PCC, and they were able to reduce the time from 127 minutes to 58 minutes. So if you think about PCC reversal for VKA, I just can highly recommend to have the 4-factor PCC somewhere in your emergency department to avoid any delay. So now let's switch gears. You know, since 2008, we have the direct oral anticoagulants. The Bigetran, the direct thrombin inhibitor, was actually the first, followed by the 10A inhibitors, rivaroxaban, apixaban, and edoxaban. And worldwide, we have seen a huge uptake in the market of prescribing the DOACs. And one advantage of these DOACs, of course, was they're easy to use, no need for monitoring. But what is really important and striking is the lower risk of bleeding, of major bleeding, which is very much reduced in the DOACs. However, there is a residual risk of bleeding. Any patient that is anticoagulated, of course, also have an increased risk of bleeding. And for those patients, again, similarly to the VKA patients, we need to have a reversal strategy. And currently, what we have in the different guidelines, ERA, or from the European Stroke Organization, is the use of a specific antidote. But I'm also aware, and I will come to that a bit later for the 10A inhibitors, that many of us do not have a specific antidote for the 10A inhibitors for several reasons. Idarucizumab was actually the first antidote, which was licensed in 2016 as a specific antidote for the direct inhibitor, thrombin inhibitor, the Bigetran. It's a very large molecule. It's a humanized Fab fragment, and it's actually an irreversible binding between idarucizumab and the Bigetran. And the binding affinity for the Bigetran is about 350 times higher than the Bigetran to thrombin. The open multi-center study here showing reverse AD investigated idarucizumab, published in 2017, and those patients that were bleeding under the Bigetran, uncontrolled bleeding or emergency surgery here were included, and they received 5 grams of idarucizumab. It's divided into 2.5 grams, which you can administer 2 times. So the licensed dose is 5 grams idarucizumab. Patients were followed up then here for 19 days, and a total of 504 patients were included. The primary endpoint was a laboratory endpoint, the diluted thrombin time, and you can see this here for group A and group B. Before giving the idarucizumab, on average, the dose was about 150 nanograms per mil, so it was indeed elevated. After giving 2.5 grams of idarucizumab, you see here an immediate reversal, and of course, after giving the full dose, this actually sustained also over time, and this was shown for both groups, and this was associated with a very good hemostasis. So I'm not going to show you more data in this, but clearly for us, if we have patients that come under the Bigetran with bleeding, we do a very early on therapy with idarucizumab. However, we also have the Bigetran. This is maybe interesting for you in the European market, only like 6%. So it's not very often that we actually have patients that we see under the Bigetran which are bleeding. So the majority of patients are having factor 10A inhibitors, apixaban or rivaroxaban, and the andexanet alfa has been licensed in Europe last year as a specific antidote for the factor 10A inhibitors, and it acts as a factor 10A decoy and it retains a high affinity for the direct and indirect factor Xa inhibitors. So it has been modified to remove any intrinsic coagulation activity. But it's also important to realize that andexanet alpha binds the factor Xa inhibitors, not irreversible, but it's a competitive binding. The Nexa-4 study was the study which actually led to the license of the andexanet alpha. It was a prospective open-label study investigating andexanet alpha in patients under Xa inhibitors which were bleeding. There were a lot of major exclusion criteria, and that's why most of the patients that were included had a GI bleeding or an ICH. And we have no data from the study or about the combined use of PCC, fresh frozen plasma, and andexanet alpha, because those patients were excluded. So it was a little bit kind of an artificial setup. The primary endpoint was a proportion of patients with excellent or good hemostasis. The reversal of the factor Xa activity here for apixaban is shown on this slide. 134 patients, you can see at baseline an elevated level of 150 nanograms per mil. After giving the bolus of andexanet alpha, there was a full reversal. However, andexanet alpha has to be given because of short half-life and competitive binding over another 2 hours, so bolus plus 2-hour infusion. And during this infusion time, it was also decreased, no relevant apixaban levels. However, after 4 hours after stopping the infusion, there is a rebound of the factor Xa activity. However, despite this rebound in the study, there was an excellent or good hemostatic efficacy shown in the study. So that's why andexanet alpha now got licensed for patients under rivaroxaban or apixaban that have signs of life-threatening bleeding. One important thing to see here are the safety events. We have about 10% of patients that had thromboembolic complications after the use of andexanet alpha. This is pretty high, and it's thought that this might be associated with an activation of the tissue factor pathway inhibitor. This is something that needs to be followed up. The death rate here of 14% can be seen in the context of majorly having patients with ICH. So the major drawbacks of andexanet alpha include this kind of difficult regime of an initial bolus plus 2-hour infusion, potential elevated thromboembolic complications, and substantial costs. So we had a long discussions. Can we actually afford this antidote for our patients? And the problem is that the andexanet alpha currently is the only licensed drug for the reversal of factor Xa inhibitors. So what are other options? What is about the use of 4-factor PCC as an unspecific measurement to overcome the anticoagulatory effects of the factor Xa inhibitors? And indeed, if you look again these different guidelines, we can see as a second option, following initial antidote therapy, if we do not have andexanet alpha available, we may want to consider the use of a 4-factor PCC, and we have doses between 25 and 50 units per kg. We have one major study actually which has investigated the 4-factor PCC. The study was published from Amar Majid in 2017 and Sam Schulman, so-called UPRATE study. This was a study which investigated the use of the 4-factor PCC in patients under rivaroxaban or apixaban with acute major bleeding and signs according to ISTH, so bleeding in a critical organ, or fall of the hemoglobin more than 2 grams per liter. Also, the last dose taken of rivaroxaban or apixaban had to be within the last 24 hours. Unfortunately, in the study, no factor Xa levels were actually measured. Patients with these inclusion criteria, they received a 4-factor PCC given as a fixed dose between 1,500 and 2,000 units. Bleeding location, not surprising, maybe ICH, 70%, and GI bleeding. The majority actually had a non-traumatic bleeding. And here you can see the median dose treatment with PCC. It was about 27 units per kg. So when we go back and reflect on the recommendations, we should give between 25 and 50. So we're here in the study more or less at the lower end, so the smaller dose. However, the efficacy was very good, 70% in this cohort. And the study actually was not only performed in Canada, but also in Sweden in parallel. And both study cohorts showed here for the termination of bleeding, restoration of hemostasis, 70%. So it seems from this observational data that the four-factor PCC is quite effective in restoring hemostasis following bleeding under factor Xa inhibitors. Of course, now it's interesting to see what's about the four-factor PCC versus andexanet alpha. There's a current study going on, the so-called ANNEXA-I study. However, currently we have no data, and that's why Sam Schulman compared those data from the ANNEXA-4 trial with the upright data, and what he found was that the expansion of hematoma in those patients with ICH was similar, treated either with andexanet or factor PCC, which means that four-factor PCC had a similar effectiveness with regard to reversal. However, we have to, of course, interpret this data with caution because this was not a one side-by-side study, but these were different studies. Duration of bleeding also in our observational cohort here from Germany, very similar results for DOAC-treated patients with a CNS bleeding. You can see again, similar with the VKA, the duration of bleeding was significantly here shortened when the patients received the four-factor PCC. This is also here confirmed in the meta-analysis effectiveness of four-factor PCC, 340 patient effectiveness of controlling hemostasis was about 80%. So we have no data showing that four-factor PCC is used for the reversal of VKA. There's growing evidence also to use the four-factor PCC for DOAC reversal. However, we are very liberal, at least in Germany, Austria, and Switzerland. I think most of you know already that in acquired bleeding of any other cause, we also use the four-factor PCC. We now, and we have learned about a lot about the trauma-induced coagulopathy, massive bleeding, but we can also transfer to different settings, which will all, at the end, sooner or later, will lead to a coagulation factor deficit, fibrinogen deficit, or reduction of coagulation factors with an impairment of thrombin generation. And you know, I've heard, especially in Sri Lanka, you have a lot of ROTEMs, a lot of viscoelastic methods. And when we try to put this complex coagulopathy following major trauma or major bleeding, we have to, of course, do it somehow simpler in a clinical context. And what we first address, of course, is this clot stability, hyperfibrinolysis. We have very good data for the use of tranexamic acid. Clot strength is the second part that we address, fibrinogen and platelets. And third, if we have bleeding, despite having clot stability, despite having clot strength, then of course we also have to think about the depletion of coagulation factors, including the factors 2, 10, and 7, which also of course lead to an impairment of thrombin generation. And a very nice study here from Austria, from Petra Innerhofer, actually investigated in the so-called Retic Trial the use of coagulation factors, ROTEM-guided, so viscoelastometry-guided algorithms in those patients that had a severe bleeding and a trauma with the ISS higher than 15. And those patients here were randomized to receive either fresh frozen plasma, 50 ml per kg, or coagulation factors, first fibrinogen, second then four-factor PCC according to a ROTEM algorithm, and the primary clinical endpoint was the avoidance of MOF and the need for massive transfusion. If we just look here at the first treatment loop, we can clearly see that coagulation factors here were significantly, of course, faster in the patient. So if we have to do fast therapy, we clearly want to go for this correlation factor approach. Looking at massive transfusion, this was clearly significantly reduced in patients that received correlation factors. However, MOF, multi-organ failure, was not significantly different between both groups. However, the study was early terminated because of this result, that those patients that received fibrinogen plus PCC had lesser degree of massive transfusion. So in the context of trauma, we have also, again, more growing data that show that the use of correlation factor concentrates are superior to fresh frozen plasma. Other areas of interest, of course, is cardiac surgery. We know that after cardiac surgery or during cardiac surgery, we have an impairment of thrombin generation. We have seen this from several studies. But up to now, we had no randomized controlled trial actually investigating four-factor PCC in this context. And the first study, and this was done now by Kiba and Kayakuri, which was just published, investigated the use of four-factor PCC in the so-called FARS study. And this is more or less a feasibility study. Can we actually give a four-factor PCC as first-line treatment in bleeding patients undergoing cardiac surgery, as opposed to the fresh frozen plasma group? You can see small numbers. However, this was a feasibility trial. But despite having these small numbers, and I was quite surprised actually myself, there was already a significant reduction in the 24-hour chest tube drainage, which means that those patients that received the four-factor PCC had less bleeding, and they also had a reduced transfusion need for allogenic blood components. So very good data, very encouraging data. Again, this is the first randomized controlled trial in this setting. What's about the safety? What's about adverse events? And here you can see the very different adverse events, and you can also see that the number was really low, and there was no significant difference between those patients that received fresh frozen plasma or four-factor PCC here in the context of cardiac surgery. Of course, there will be a follow-up trial, a big, large randomized controlled trial, which will inform us more about the use of four-factor PCC outside VQA reversal in acquired deficiency in cardiac surgery. Coming back to our guidelines, again, European trauma guidelines, which suggest that if your patient is bleeding, fibrinogen levels are normal, then you may want to consider the use of a four-factor PCC. And especially if you use the viscoelastic method and you have signs of delayed coagulation initiation. So I would like to show you at the end of my talk one case, which is another indication for the use of the four-factor PCC. So this was a 2-month-old infant, which we treated last year. The little one actually showed gushing, vomiting, and opistosis. This was all for the first time. We did an MRI scan, and this patient actually was transferred from a smaller hospital because there were signs of bleeding. And it was then shown that there were multiple hematoma intracerebral, which needed to be, of course, immediately being operated. So our neurosurgeon wanted to go ahead and place ventricular drainage. I was called myself this evening. It was around 6 o'clock. And the first lab parameters showed a PTT, which was not measurable, PT was not measurable, and also the ACT. I couldn't believe these results, so I said, okay, let's try and get some information from the parents. Unfortunately, there was not much information to get at that time point. However, it seemed that there was nothing in the family. And those of you who are familiar with ROTEM, this was a ROTEM trace. So again, confirmed what we have seen before, PTA, PTT not measurable. So there was no coagulation going on in this little one. So the question was, how do I treat this patient now? I actually was not quite sure. So what I did was I gave this patient tranexamic acid, fibrinogen, and also the 4-factor PCC on an empiric basis. As you can see here, the normal coagulation trace. So after giving this cocktail of coagulation factors, I had a whole normalization of the rotem trace, and also the INR and the APTT were fully normal. What I also did was, before actually putting the therapy in, I did a single factor coagulation analysis, which of course I received later. And it was shown that the vitamin K dependent factors were not measurable. So the problem here was that vitamin K was actually not resolved in this little one, and that's why these coagulation factors were not measurable. So again, for the label indication for the 4-factor PCC in Europe, acquired deficiency, for instance, VKA, trauma or cardiac surgery, and of course also the congenital deficiency. With this, I would like to close my talk and remind you also to implement, and I'm sure that you're very advanced in Sri Lanka about the patient blood management, that we want to address this by using POCT methods, POCT coagulation methods, to try to individualize somehow on our therapy, coagulation therapy, and also try to use coagulation factors. So thank you very much, and I'm happy to take any questions.